As you think about patients getting frontline osimertinib, what are your thoughts on understanding resistance to osimertinib when patients develop acquired resistance after they have been through first-line osimertinib? And can you talk about strategies that you recommend people to use in their clinic and also some directions for research?
So the acquired resistance mechanism to osimertinib in a frontline setting already presented last year, and there are a lot of diverse mechanisms, including loss of T790M mutation, small cell lung cancer transformation, and most commonly c-Met amplification. So in our routine practice, there is no approved drug that has shown a clinical benefit in any of resistance mechanism after progression on osimertinib. So currently, cytotoxic chemotherapy, usually pemetrexed and platinum combination chemotherapy, is the most commonly used in our setting. But there are many clinical trials targeting c-Met amplification, small cell lung cancer transformation, and other genomic alteration. We are eagerly waiting for the mature data of these clinical trials, especially AstraZeneca-driven TATTOON study or Savannah study that is being tested for osimertinib and c-Met targeted agent in the setting of c-Met amplified or c-Met altered EGFR mutated non-small cell lung cancer.
So maybe just to build up on that a little bit, I agree with you that resistance patterns are quite diverse, but there are ones that can be targeted, and I think in clinical practice we do test individuals who progress. If they have a targetable alteration, we can enroll those individuals on clinical trials. If they don't, then oftentimes they get chemotherapy. So it is an evolving landscape, and we will continue to learn, but I do think it's still worth testing patients who progress, because there may be things there that you can do for your patients today.
Pasi, a common clinical scenario is you have a patient newly diagnosed with lung adenocarcinoma, stage 4 disease. You already have the PD-L1 results back. Let's say the PD-L1 comes back at 80%. Molecular testing results are not back. What is your approach in that situation for that particular patient?
Yeah, I think I agree with you. It's a common because PD-L1 testing comes back by immunohistochemistry, and sequencing may take longer. I think it depends a little bit on the patient. Certainly in an individual that clinically would be likely to have a targetable alteration, someone who, for example, is a never smoker or a limited smoker, in those individuals we tend to wait for molecular testing, because the likelihood of finding a targetable alteration, EGFR, ALK, others, is quite high, and as long as there's no immediate clinical need to treat that individual. I think if there are other scenarios to present, I think the situations, for example, if you need to treat somebody, then that may drive a treatment decision earlier. But I think we want to be most informed about how we treat our patients, and I think incorporation of molecular testing in that regard is important.
So wait until the molecular testing is fully done. You have all the results before you act upon.
Right. That is the ideal situation.
Whenever possible.
Whenever possible.
Right.
Obviously, not everybody fits into that, but I think that's the optimal from a therapeutic standpoint.
Now, does the faculty panel here also agree that for a patient with a targetable mutation, like EGFR, the frontline therapy should be a targeted drug as opposed to immunotherapy or chemotherapy?
Well, just adding to what was said, indeed, you should give the best therapy first, and you should make the best choice as well. So it means it's better to wait for the molecular data before you make your choice. And most of the patients can wait a bit. I agree there are exceptions, but in general, it's best to have everything at hand before you make your decision. And then the question that you're raising now, I think there's no doubt these are two different worlds. And if you have an oncogene addiction, your treatment is TKI, not immunotherapy.
Yeah, and then we also remember that the predictive power of tumor PD-L1 expression is quite low, especially in EGFR mutated lung cancer. So we should be very careful in treating EGFR mutant lung cancer with immunotherapy.
Yeah, and I think, at the moment we have sort of 5 molecular targets where we have targeted therapy, which we can begin as first-line treatment. I think that number is only going to increase as we move along the next few years, and it could be that we need to test for 7 or 8 different things, and I think that, again, it's about matching the right treatment to the right patient.
One of the things that I've heard other colleagues say as well is if you're compelled to start a patient on some form of therapy because they're symptomatic and their condition is declining and you don't have the molecular testing back, it's better to start with chemo alone, not have chemo plus immunotherapy until the results are available, because if you have to move to targeted therapy, it's a lot easier when immunotherapy is already not on board. Is that something you have done in your practice?
Yeah, absolutely. I think you're getting at one of the issues is that there are interactions with targeted therapies and immunotherapies, and so that's an issue. I don't think you do a disservice to the patient that if you do one cycle of chemotherapy alone and then add immunotherapy later if there's no targetable alteration. But I think if somebody needs to be treated, and I agree with Johan, it's usually the exception as opposed to the rule. I think chemotherapy is a fair choice.
Moreover, if you give chemotherapy alone, you stay within the label, because these studies, at least with pembrolizumab, were done in non-oncogene addicted patients.
Correct.
And one last issue I want to cover on this topic before we move on is a clinical scenario where the plasma was sent for testing, and plasma cell-free DNA testing reveals EGFR exon 19 or 21 mutation. Is that enough information for you to proceed with osimertinib as frontline therapy, or would you still wait for the tissue? Joel?
It's a really hard question. There is a lot of temptation to use osimertinib or other EGFR tyrosine kinase inhibitor just with plasma liquid biopsy testing. Based on very high sensitivity and specificity of a plasma liquid biopsy for EGFR mutation. But it's always a regulatory issue. So without tumor tissue examined by pathologists, it's really hard to give any kind of cancer therapy in our routine practice. But I do believe that kind of practice will be available and feasible in the very near future.
So in the United States, that is already available.
That is already available and approved, right? So I think if, as long as you have a diagnosis of cancer on a pathology, I think if the molecular testing comes from blood as opposed to tumor and it comes back quicker, I think that's I think that's a perfect scenario to use targeted therapies.
Great. So that's been a great discussion on EGFR targeted therapies. We have osimertinib as the preferred frontline therapy agent with a median survival of approximately 39 months.